I'm your host, Avery Brooks. We're at the Spine Center of Southeast Georgia. Today's health segment is all about spinal cord stimulation. Please join us as we talk with Medical Director Dr. Christopher Bovinet. Stay tuned, it's all coming up next right here on Golden Isles TV. Hi, welcome back to Golden Isles TV. I'm your host, Avery Brooks, and we're here with Dr. Christopher Bovinet, otherwise known as Dr. B to his patients. How are you?
I'm doing well. How are you, Avery?
I'm good. Tell me about how you got started, where you're from, and how you got started in this specific type of medicine.
Well, I wanted to be a doctor since I was 8 years old, but I started out wanting to do pediatrics, working with kids. I love children. I love my 2 boys at home. But a pediatrician told me a long time ago, do you want to see your kids or everybody else's? And I'm like, you know what? Someday when I have kids, I'd like to see my own. So he talked about different things. He's like, I think you'd be good at this spine medicine and pain medicine. At first he told me, do anesthesia, but it's 90% boring, 10% panic. I'm like, no, that sounds awful. I don't want the boring or the panic.
Right.
So I went into orthopedics and I thought that was cool. It's like human carpentry, bones heal, started doing all this stuff. But after a few 39-hour straight shifts, because in Michigan there's a lot of snow. This is where I trained at. So medical school at Michigan State and started residency there. But where there's all the snow, there's snowmobiles and there's snowmobile accidents and then there's snow machines or snow blowers, we call them. And they get clogged up with snow. So we put their hand in there, get their fingers chopped off, and we have to fix those. So I would go in at 4 in the morning and sometimes I wouldn't leave till 7 p.m. the next day. So I did that twice. So after a couple 39-hour shifts, like, no thanks. It was fun, but no thanks. And someone's like, well, what about PM&R? Like, what's that? Well, it's kind of like ortho without the crazy hours, without the surgery. That sounds interesting. So I switched over to that and loved it because I got to be a hybrid of like a neurosurgeon working with the spine, a neurologist doing the brain injury, spinal cord injury, doing orthopedics like joints and bones and the spine itself, and then doing this pain management. And I kept seeing everybody limited participating in physical therapy or not being able to work or function or just live their lives with their family because they were limited by the pain. So I was like, that's what I like to go into.
Right.
I also was personally involved in a car accident, injured myself. I've broken multiple bones throughout the years, so I've felt a lot of pain, had some surgeries, and always hated pain pills. I could count on one hand how many I've had my entire life because they're awful. But it's a big problem here we have in this country where we have 5.2% of the world's population, yet we consume 90% of the world's pain pills.
Wow.
And 77,000 people died last year because of it. So, that's what I'm trying to do is try and get people off the dope to try and have them out. So that's what I've kind of dedicated my life to do. So as I said, I did residency, started at Michigan State, then I went on to Medical College of Virginia, did the residency there in physical medicine and rehabilitation, and went on to their accredited pain fellowship and spine fellowship, and I was their chief fellow, and then now I'm down here. So I'm the medical director of this place, the Spine Center Southeast Georgia, and this is where the magic happens, if you will. It's our certified, ambulatory surgery center called the Brunswick Pain Treatment Center. I'm the medical director of both. That's where I've been working the last about 5 years. So.
Wow, well, you're very busy and you wear a lot of hats, and so honorable that you've dedicated your life to this so that people aren't, always resorting to pain meds, but more a procedure that can help long term.
Absolutely, and there's lots of different options we have. I tell people low back pain is the most common complaint we see. 90% of all adults will have back pain at some point in time in their life. So the good news is they'll never be out of a job.
Right.
The bad news is people in this country think all there is pain pills. So, and what Dr. Gage talked about previously, and through September we had Pain Awareness Month. So we had t-shirts and really putting out flyers out there, talking to referring doctors as well as other patients, but there's alternatives to pain pills. I gave a 3.5-hour lecture to all the doctors at the hospital early September talking about the risks of opiates and their dangers and alternatives to them. So, and that's what I try and do every day. So in the lower back alone, there's about 58 different things I could do without pain pills to treat low back pain. So and one of which we'll talk about in much more detail.
Yes, I was going to say one thing, we're actually here with Dr. Bovinet today to speak about spinal cord stimulation.
Yes, ma'am.
And so let's talk about that. Tell me about that, and what is spinal cord stimulation?
Well, it stimulates the spinal cord to block pain signals from getting to the brain. It's kind of like a pacemaker for the spine.
Okay.
But unlike a pacemaker that's in the heart, this is not in the heart. It's not in the spinal cord. It's not on the spinal cord. It's not touching it. It's behind the spinal cord in the epidural fat and what cushions it.
Okay.
It is inside the bony canal, but it's in the fat behind it. And it stimulates the spinal cord with very gentle electricity that you may feel with some of the more traditional or older spinal cord stimulator systems, but the newer ones make it so you don't feel anything.
Wow.
Kind of like a dog hears things you and I can't hear. Doesn't mean we're deaf or dumb. It's just too high of a frequency our ears, our brains can't perceive it. So these stimulators go at a much higher frequency at 10,000 hertz. That's 10,000 times per second.
Oh my God.
So we can't perceive it.
Right.
So you could stop that pain. Instead of replacing with pain pills or replacing with buzzing, replace it with nothing.
Great.
It's
Sounds
cool
wonderful.
system. Yeah.
Dr. Bovinet, tell me about spinal cord stimulation. This is actually a model, and you're going to demonstrate a little bit about the procedure.
Yes, ma'am. So this is a spine model. This is the lumbar spine through here, or the lower back, the 5 bones. Here's the sacrum, the tailbone, and here's the mid-back. These are examples of little wires that actually go inside the spinal canal. Again, it's in the epidural fat, not in or on or touching the spinal cord. They're little, like pieces of cooked spaghetti, thin, very flimsy, so they don't damage the spinal cord. They move with you. And this is an example of a battery. This particular one is called Nevro. It's Latin for nerve. It's a company that's been around. In the U.S., they've been around a little over 10 years, but they got FDA approval May of 2015 and went into a few select large cities in July of 2015. Didn't come here to Brunswick by way of Savannah until May of 2016. And I was the first to do a Nevro spinal cord stimulator here in Georgia outside of Atlanta, since they got it first. And now we have unbelievable success with it. Traditional spinal cord stimulators, we used to call it the 50-50 club. 50% of people it worked for, and they got about 50% pain relief, and that was at best. What we're seeing with this one, they did the longest and largest stimulator trial in the world. It was 2 years long. What they saw was about 80% of people got at least 50% pain relief. And traditionally, in medicine, we want to have evidence behind everything we do, and a lot of spinal cord stimulator companies and a lot of procedures we do is lacking evidence. But this particular company is really an evidence-based company, and they want to get level 1 evidence, the highest level of evidence there is out there. So they did a randomized controlled trial. They took one of the gold standard companies, which is Boston Scientific, and they said, all right, you said you're good at getting back and leg coverage, so we'll go up against you. So they kind of put in their stimulators with their best doctors and their best reps programming it. And Nevro did the same thing in this other arm. And this is after they took all the appropriate patients, divided them up evenly, and appropriate age, pain scores, things like that. So it's even, so it's randomized and it's controlled. The patients didn't know which one they were getting, and then they followed them out. The FDA said do it for 3 months, and if it's just as good as, or at least no worse than Boston Scientific, you'll get your approval. Basically, they showed that they were statistically significantly superior. They were much better than. So Boston Scientific got about 50% of people got 50% pain relief. And what we saw with Nevro was 80% of people getting at least 50% pain relief, which is unheard of.
Yeah.
And they had a separate group in the study that only had back pain. And traditionally, that's the toughest thing to get. Legs, actually quite easy to alleviate that pain. But back pain was very tough. Traditionally, we tried pain pumps or nerve blocks, ablations, other things that weren't quite that effective. But this subgroup, again, those people had 80% pain relief as well. Or 80% of those had 50% pain relief. So they carried this study out. They self-extended after the FDA approval and that superiority label. They went all the way out to 2 years. And they kind of saw 70 to 80% of people that whole time were getting at least 50% pain relief. Personally, I've done probably about 155 or 160 of this company, and I have a little bit better than 94% success rate with them.
Wow.
And the average pain relief is a little better than 77%. So
that's great.
So we're getting even better selection, or at least better outcomes that they were seeing in the study, which is fantastic. So.
Yeah, there's so much science behind all this, so many numbers, statistics, and testing that has really proven that it is effective. What I find interesting is that you were saying that it doesn't go in the spinal cord, but it's in the fat.
Yes. Yeah.
Tell me a little bit more about that.
So I actually did one just before we met here today, and this afternoon. But basically, I have a patient lay down, so their spine would be like this. We sterilely clean them and prep them and drape them, so they're only covered, or they're covered up, but they have only an opening, just over that area to keep the rest of them sterile. If they like, they can be sedated. Some people choose to do without sedation. It's actually not that uncomfortable. It's not much more than having an epidural. So what I do, once they're ready, whether they want to be put to sleep, relax a little bit, or they're fully awake, I'll numb the skin. So usually at a spot about right here, then numb down to where I'm going to put the needles in, the entry point into the spinal canal. Wait for it to numb up, and then actually put another longer needle in and numb all the way down. So I fully numb the tract. So I kind of numb each side twice. Once it's numbed up, I nick the skin and put a little needle, just done all through a needle, what we call percutaneously, meaning just through the skin. I put a needle inside through there, okay? Take the stylet out, I confirm I'm inside the space, and then I put this flimsy little wire inside the spinal canal, okay? You can see here it's in behind the spinal cord. It's probably tough to see for the viewers at home there, but it's in behind the spinal cord and the epidural fat, okay? And just a brief reminder of anatomy in the center. It's like my fist is kind of like the brain, then you have your spinal cord going down. Around that is cerebrospinal fluid bathing it. Around that is 3 layers of meninges that hold in the fluid. It's kind of like wax paper to hold it in. And around that is that epidural fat that cushions it. So way back there, that's where those 2 little wires go in.
Okay.
And they said they're only 1.4 millimeters wide. And we always check imaging beforehand to make sure it's not too tight and make sure there's plenty of room. And usually there's a lot of room in there to fit those. Okay. So I get those leads into place, and then I could steer them. They're not hooked up to the battery when I put them in. There's a little tiny wire stylet that goes inside there, and I could steer it as I'm putting it in there. And I get it to where I want it, pull the wire out, and I secure it to the skin. And then the patient gets to go try it out for a week.
Oh, wow.
That's the coolest thing about this. There's no other surgery someone could try out. I mean, this is a minimally invasive procedure, and then if successful, it's a minimally invasive surgery to put in. But there's no other back surgery you could have. There's no, not that you need it. Your nose is lovely, but see, you won't have a nose job. You can't undo it afterwards.
Right.
It's done. You
Yeah.
can't have your gallbladder out. And you know what? I
put
got
it
too much
back in.
diarrhea.
Yeah.
Put it back in. You can't do that. The damage is done. And
Right.
if you have spine surgery, they cut away the bones.
Oh.
They take out the disc. They, cut away some of the muscle, and then they start sewing things back together. You can't undo that. If it doesn't work, you're out of luck. We used to think that back surgery is pretty successful. We used to thought it helped about 50% of people. But newer numbers aren't that good. We're seeing about 1/3 of people when they have back pain are getting better. 1/3 stay the same, and 1/3 get worse. So what else can we do? So this came along, and actually the first one was done in 1967.
Wow.
Dr. Norm Sheely and his neurosurgical resident at the time, Harold F. Young, who I trained with at the Harold F. Young Neurosurgical Center in Richmond, Virginia, they did the very first one. Unfortunately, it wasn't that helpful because they put it directly on the spinal cord.
Ooh.
We learned how to do it since then a lot better, and
Yes.
how we put it, and the technology's improved with different advances in wires. The batteries have gotten smaller. Just with this company, there's their first generation battery. To the second generation is much smaller. It's like a stack of silver dollars, if you will. But this, they trial this just with the wires for 1 week.
Okay.
And see if it helps their pain at least 50%. Okay, does it help? Decrease their need for pain pills? Does it improve their function? Can they stand longer, be more active, take care of their activity of daily living? Can they keep working, take care of their families? Can they sleep better? Does it help their mood? Because with chronic pain comes fear, anxiety, depression, avoidance of activities that cause the pain. And then can we help their sleep? So if we do all that, we do what I really try to do is get their life back, improve their quality of life. I tell people I rarely save lives, a couple times a year, but it's usually at a hospital, on an airplane, or through CPR or something. I don't ever want to do it here.
Right.
But improve quality of life is what I do every day. So if it does that, and they're excited at the end of the week, well, we actually pull those leads out just because temporarily they're inside their spinal canal, but they're sticking out, hooked up to an external battery, and they try it for that 1 week, as I mentioned. At the end of the week, we pulled them out. They said that was amazing. Like, they don't want to give it back. They want to leave them in there.
Yeah.
Well, then they get set to put in permanently. The little wires go in via a small incision, and then you can put the battery in the fat of their back.
Okay. Yeah, I was going to say, where does it go with that?
Usually in, right here in the back, or the buttocks, but normally right here where people could reach. And the batteries are guaranteed for 10 years, so a little longer than a pacemaker. They kind of, how you make it, you make a little pocket. You cut the skin a little bit and create a little pocket in the fat, and that slides right in. The wires slide right into that, and you have a little like glasses screwdriver you lock them in with. Okay. And then in 10 years, sometimes they go longer, you leave the wires in place, you just unscrew the wires, put in a new battery, which could be even smaller and last even longer in the future, because we've seen them.
It's getting better and better and better and better, smaller and smaller.
Other companies had even bigger batteries over the years prior to the advent of this particular company and their battery. So they've gotten smaller over the years and more refined. So it's been a wonderful technology, a wonderful tool for my patients. We used to use it only after they failed back surgery, or if they had a thing called complex regional pain syndrome, where they get this unrelenting nerve pain and swelling and colored, changes in their leg or their arm, and pain out of proportion to stimulus, like things like the sheets touching their leg hurts, or clothes touching leg hurts, shower water, the fan blowing air, unbelievable pain. So those are the two main indications. They've expanded the indications over the years, and this company has really dedicated themselves to research, being an evidence-based company, that they're proving that it works for non-surgical refractory back pain, meaning there's no surgery that needs to be done. It's just chronic back pain that the surgeon said, nope, I can't do anything to fix it. So they try this after maybe other shots or therapy or chiropractic has failed. They do it now for peripheral neuropathy, which is a big problem we see like in diabetics, or patients that had a history of cancer treatment, thyroid issues, a number of causes for it. We've seen it for lots of other post-surgical syndromes, but now I've had a lot of referrals from surgeons that say, the surgery may or may not work. Why don't you try that stimulator? Because the beauty is you get to try it. If it works, wonderful,
Right. So you think this might be like the first step before any other surgery is considered? It's like the first step.
It can be. I mean, there's no perfect cookbook in medicine. It is definitely an art and a practice of medicine. So we always try the simplest stuff. So try physical therapy, try weight loss, activity modifications, maybe try an anti-inflammatory if appropriate, or Tylenol. Try different things like that. If that doesn't quite work, we might try different injections. We're still trying to fix pain. Sometimes things can't be fixed. Sometimes the damage is done. Like if you cut yourself, you get a little scar, sometimes it's still irritated. It's closed up, it's healed, but it just never healed correctly. You still kind of hurt. So this it's like a high-tech Band-Aid. It stops the pain from getting to the brain. Basically, I tell people it's kind of like you're the pain and you hobbling slowly to the bathroom. The bathroom is the brain. Okay, so the pathway or the hallway here to the bathroom is the spinal cord. And you hobble very slowly because pain travels on slow nerve fibers that go at less than 2 meters per second. And the stimulator stimulates very fast nerve fibers in either the dorsal column or the dorsal horn, meaning the back part of the spinal cord, that gets very fast to the brain. Okay, so it's like me being stimulated. I run as fast as I can down the hallway, and I get to the brain, the bathroom, and I lock the door so you can never get in there. So the brain never knows it hurts again. So it stops the pain signal from getting to the brain. So if it could be fixed, we always try and fix it. If there's no fix, what can you do to cover it up without doping you up with pain pills?
Dr. Bovinet, this is great information. We've just been talking about the procedure and exactly how it works. Tell me, is it safe?
Absolutely. It's not much more involved than like an epidural injection. And a lot of people, when they think of epidural, they think about when they had a baby. which is not true.
We try not to think about
yeah,
that.
That's actually a spinal. It's been misnamed, and I think if you ask a purist or anesthesiologist, say it's a spinal.
Okay.
Usually they're getting back to that brief anatomy we talked about. An epidural injection is done in that epidural fat. When they do a spinal, or when they call it an epidural for a woman having a baby or someone having a back surgery or leg surgery, they go through the epidural fat, through those 3 layers of meninges into that fluid, and they put a ton of numbing medicine in there, and unfortunately doing it effectively blind. You know, they're not using like the extra machine that I have here to see exactly what they're doing. They're doing it by feel, which, you know, I do it by feel as well, and incorporating with the extra machine, using the tools I have available to me, but I'm not going that deep. Then once I'm in there, there's other things they do to confirm it. So it's not as deep. You're not going to hit those nerves. You don't go too deep. So you don't really have the spinal headache. You don't have to lay down the next day and all that. So, but yes, very safe. I haven't had any complications with 500, 600, 700 of these things over the years.
Wow.
You know, extremely safe. There is a risk of infection, but I've never had one, but there's always that risk. So I give people antibiotics beforehand to prevent that. I make sure there's no infection coming into it. If they have one, we'll postpone the procedure till they're, you know, nice and infection-free.
Right.
If you went way too deep, you could hit a nerve, but that's, you know, you want a skilled practitioner doing these. Like I said, I've done several hundred with over 94% success rate, so I've had great success with them.
Absolutely.
So in the right hands, these are extremely safe. In the wrong hands, still safer than surgery, but the risk is a little bit more than an epidural.
Right. Okay. And we talked a little bit about this, but who would qualify for this stimulator?
People with chronic pain that's been there for at least several months, that you know, is at least moderate to severe. So if on a rating scale 0 to 10, 5, 6, 7, 8, 9, 10, that has failed other conservative care. So they've tried physical therapy or chiropractic care. They've tried activity modifications to reduce their pain. Maybe they've tried some different shots, and some people even tried surgery. You know, so if they're either they've had surgery and it didn't work, or there's no surgery indicated, either by the surgeon says, you know what, I don't think any surgery would benefit you, or the patient doesn't want a surgery. Okay. And then one thing is what we call no progressive neurologic deficits. If they're getting progressively weaker, there's something neurologically wrong. You know, you want that evaluated. They might need surgery or something else for that. But neurologically stable, yes, they have pain, yes, they have numbness, but they're not getting a progressive or worsening foot drop, for example. They're not having accidents with their bowel or their bladder. You know, things aren't worsening. Make sure they're stable neurologically. There's nothing that can be fixed. You know, if there's nothing that can be fixed and they've tried all the simpler stuff, it's reasonable to try this. And as I said, it's becoming earlier in our treatment algorithm. You know, surgeons are recommending it, that saying, hey, go try that because it works wonderful. Save yourself the big surgery that could take a year or more to recover. And that's if it works for them.
Right.
You know, because unfortunately there is the old joke that if you fuse, you lose. You know, once you fuse one segment, you know, the segments above and below are getting overworked, you know, because every joint in your body is meant to move. It's kind of weird, but even the bones of your skull move a little bit, kind of like your chest expands when you breathe. You know, the bones of our skull move slightly, but obviously our fingers move more, our spine moves more. And if you fuse, you know, 1, 2, 3 or more segments, or even just one at all, that motion is lost there, and the work still needs to get done. You still need to move so the joints above and below get worn out. So I tell people, it's kind of like you're working in an office, and you have, you know, 5 office workers, the cubicles, and then you got a manager right here. And if you fuse a few of them, well, the work still has to get done, so it's going to spill over up here and here. So then they're going to get overworked, you know. And then the surgeon's going to fuse there. And they get overworked and fuse there. It reminds me when I was a kid playing baseball, I put your hand on the bat, you figure out who bats first by who put their thumb or the butt of the bat like that. So you don't know when you stop.
Yeah, absolutely. Well, what a great alternative to surgery. And like you said, actually surgeons are recommending this really as a great option. Does insurance pay for it?
Absolutely.
That's important to know, right?
Yes, as I said, it's been around for over 51 years.
Okay.
You know, the first one was done in March of 1967, and they've gotten a lot better since that time, and insurance has seen the evidence. They do approve it. I've seen all payers, from Medicare to United Healthcare, Blue Cross Blue Shield, Anthem, you know, all these pay for it. TRICARE, Workers' Comp, they're all paying for it. So in the appropriate patient, of course.
Right,
You know, so
absolutely.
the beauty is they pay for a trial.
Okay.
Something you could try out. And if that's successful, meaning it helps alleviate your pain at least 50%. Again, I want more than that. I want at least 50% pain relief, hopefully more like 80.
Right.
You know, but improved function, decreased need for your pain pills, you know, improved sleep, improved mood, and get that quality of life back, which is really what I'm looking for. But, you know, the checkbox for insurance payers, if it helps 50%, okay, sounds good, you met the qualifications, we'll pay for the permanent implant.
I see.
And
Okay.
subsequent battery exchanges if and when needed.
Interesting. Even 10 years down the road.
Yes, ma'am. Absolutely.
Wow. Wow. Okay, so that's what my next question was, how successful is it? But we've talked about how, you know, the insurance needs to know that it's at least 50% pain relief. So long term, basically, if you put this in and it is successful, somebody could not have another procedure for 10 years. I mean, tell me about that.
Potentially, yeah. I mean, other things can arise during that time. This effectively alleviates nerve pain. So like sharp, stabbing, burning pain, pain that never goes away, pain that might wake you up at night. If you only have achy, dull, tight pain, pain that is only when you do certain activities, like, hey, it only hurts when I stand and walk, but I sit, I'm fine, I lay down, I'm fine, I lean forward, I'm fine, might not be a candidate for this. But the pain is always there. It would probably help alleviate that pain. But sometimes when pain's that bad or you had other surgeries, there may be other things going on, like some arthritis. You know, a lot of times these don't help the arthritic pain, but usually nerve blocks and ablations are very effective at that. So there's other things we could do that typically we try to alleviate that pain before we go to a stimulator, and sometimes they need to be done in the future. I've had some patients that have had 95% relief for over a year, and then all of a sudden their pain comes back, and it's just in one spot, only with certain activities. You know, they go to the surgeon, like, all right, there's something wrong, I have to have surgery. Nope, there's nothing new going on. All right, check the stimulator. Nope, nothing wrong. I examine, it's just your SI joint. A simple injection to take care of that.
Right.
And still doing great now, 8 months out from that. And
Great.
that's why I tell people, it's like when I do this for them, I kind of invite them to my extended family. Kind of like we'll see at the big family reunions we do once or twice a year. You know, I don't want to see people all the time. I'm not that type of doctor. I want to get you well.
Right.
You know, and then you check in every couple of years, make sure you're still doing well.
Absolutely. Thank you, Dr. Bovinet, again for your time. We so appreciate it. You're definitely the expert on spinal cord stimulation, and we appreciate your time today.
Absolutely. Thanks for having me on. So just want people to know it's a very effective tool, but it's one of the many tools we have to alleviate back pain or neck pain, arm pain. There's many other things we have here to offer at the Spine Center in Southeast Georgia. Happy to take a look at people for any pain complaints, whether it's back pain, neck pain, abdominal pain, pelvic pain, joint pain. There's a lot of things we could do to effectively alleviate their pain without just doping them up with pills or offering them surgery. There's a lot of other things that are alternatives to that most people aren't aware of even exist. So
yes, and those alternatives, like you were saying earlier, really help people just function day to day.
Absolutely.
Without the pills, which is so important.
Yes, ma'am. Absolutely. That's what we do here. So come see me, Dr. B. I'm at the Spine Center, Southeast Georgia. Look forward to seeing you.